almost done. Then we're going to have some time to kind of discuss some of this stuff. Going bigger picture here, one of the things we'd like to take out of this talk is that, like many of the vulnerable populations in our society, we as emergency physicians have a special role in taking care of them. We are lucky enough to actually be able to care for them, be able to step into a world that we, being of socioeconomic status or background, might not be able to enter into otherwise. And this is one of these populations that preferentially ends up in the ED because of their status, because of the way our healthcare system works, and basically their documentation status. So I would challenge all of us to think about how we, as ED physicians, can think about making our EDs more receptive, more engaged, and more challenged to take better care of these patients. One of the things, I'm going to go through this little blueprint right here. These are a couple of things we think are paramount in order to really be able to advocate for this population. First of all, it's recognizing that immigration is a social determinant of health. And most importantly, it's modifiable. It's not necessarily that it is a social determinant that is unmodifiable. And what that means is that we're looking at something that influences people's health on multiple levels. It influences their level of food insufficiency, their financial insolvency. It influences their access to healthcare. It influences their access to social services. It basically puts them in a place where they are not able to use the same social safety net that holds everybody else up at a certain level. They somehow fall down below through the cracks. And we need to educate providers that that is something that this population specifically suffers from. On top of that, language is one of these things that if we do not address it, if we do not make sure that we are communicating with folks, we are not going to be able to intervene on any of their issues. Then, as we've been talking about before, and we're going to talk about more throughout SAEM, is appropriate referrals, understanding what resources are available in your community for these patients, what they're eligible for, and how to plug them in from the emergency department. The important thing is that we may be the only step in their care paradigm. We may be the only touch point to a public servant, to a doctor, to just anybody who can actually advocate for them, because they live in such, victimized, marginalized part of our society. And so it's kind of like the trafficking issue that's been made a little bit more sensationalized in the last couple of years, that we may have the one chance this person has to end up in a better place. Part of that is medical legal partnerships and being able to refer accurately, as in avoiding notarios, and as well as with a good referral conduit to legal representation that can actually take care of these patients. We're lucky enough to have that in LA. There's actually a lot more immigration legal aid than I realized, and something I've learned a lot about the last year or two, but it is definitely a geographical limitation. The other thing is advocacy. How are we addressing kind of the signage, the culture of medical settings, and how that relates to undocumented folks? How do we make them feel when they walk into our emergency department and our hospitals? And then one of the things we'd also like to talk more about is like local and national organizing. And we as emergency physicians, what can we do? How can we take more ownership of this population? How can we create connections among our group of fairly equipped social capital-wise folks to advocate for these people? So, and we'd like to challenge you guys and solicit discussion. We're going to talk more, but you know, and think about whether we can maybe have a larger group or a subsection of social EM that, you know, thinks about what is undocumented status, what is this patient population, how do we as emergency physicians really take responsibility for their care, and think about what we're doing on a day-to-day basis, and how, you know, we can share lessons from working in different places and different, you know, care paradigms, medical legal partnerships across the country.
Yeah, thanks everybody. I just want to emphasize that last point. The intention of today's panel and discussion wasn't really to, you know, we wanted to offer some of the things that we've discovered through our own practice and our own work, but the real intention was to make this part of the conversation and identify other people out there who are interested and are experiencing the same issues, and kind of further flesh out that blueprint that we put up there on the screen. So we really do hope that you guys reach out to us here in some other capacity, or maybe we'll see you at the social emergency medicine dinner, and we can kind of continue the conversation, learn more about we're all from LA, learn about your experiences in other parts of the country, what issues you face, and hopefully we can kind of collectively bring a voice to this patient population. But thanks for coming bright and early today. We're going to open it up to, we have a few minutes for questions, comments, discussion.
Sorry, we're just going to use the mic because we're recording.
I just wanted to know what, in a really busy ED environment, the medical legal partnership looks like. Like, how is it enacted? Is there a separate person? Overnight, do you have people available just at different institutions, what that looks like?
So I work at UCLA, but I trained at USC. Our medical legal partnership is at LA County, fairly busy ER. We see 150,000 a year. And what it looks like is a co-located or resource center across the street called the Wellness Center that is basically housing for intake, which is community health workers that refer people to different resources. What we do is we target people by uninsurance, because in a post-ACA world in California, we're looking at upwards of 80% of folks that are still uninsured are usually undocumented. And so we take that population, we refer them for uninsurance status to a outside the medical setting place where we have we basically have community health workers plugged into the community that have lived experience, that are able to say, hey, you're uninsured, we also have immigration legal aid, can we plug you into that? And so it's kind of a social bundle where we try to target folks based on their uninsurance status, giving them both an insurance option, because we are lucky enough in LA to have an insurance option called My Health LA, where basically it's not total insurance, but it will get them primary care access. And we combine that with saying, can we also work on trying to get you legal permanent residence? We're going to talk about that more today.
And I think I trained at Highland, but I'm at Harbor now. And when I was in residency, we started a couple medical legal partnerships. And I think, to answer your question, I think there's three different components. One is, how do patients get to medical legal partnerships, or how do you identify issues? And I think there are a number of different ways. Obviously, staff time is limited, and everyone feels like they're very busy. But I think we deployed just a basic screener in the waiting room. That was just paper-based, not integrated into the EMR. We're now working on some stuff in LA to try to get screeners into the EMR. But just identifying patients' top issues, and either had a provider or an advocate look at the screener briefly and ask people to prioritize, because often our patients have many issues, and we ask them to prioritize their top few, and then refer them over to legal services. And I think most places, unfortunately, most people only work the 9 to 5, Monday through Friday. And I think, we had lawyers who were on site Monday through Friday, 9 to 5. But that meant, even though when issues came up, many of our patients came in after hours, but we were able to get a phone number or a good way of contacting them, and we're able to get them in touch with the attorneys afterwards. So I think, the medical legal partnership basically has two aspects. One, obviously, is being there on site makes them easily accessible for patients because we know transportation is a barrier for our patients. But secondly, it's sort of a chance to get your entire department thinking about these issues and really referring people, because sort of like Todd and Shamsher mentioned earlier, people don't see these as legal issues. They don't even know they have a problem. They just accept it as fact of life. And if you're able to point that out and start that connection for them, you're often able to get them help even if the attorney's not available immediately at that moment.
So I don't want people to take the message home, though, that if you don't have a robust medical legal partnership, that there's nothing that you can do. So just to comment on how this plays out at my hospital, I work at all of UCLA, and so we don't have a medical legal partnership on site, but yet, hopefully in the future. But so what we do is that we are just informed about what the other resources are, and so we have flyers in English and in Spanish for all of the various resources in the county, so we can either refer people to the medical legal partnership at LA County USC, but there's also neighborhood legal services and other groups, and so it just takes getting familiar with your kind of local resources. And then also, in addition to that, there's a lot of national organizations that have been putting out just general information. Like there's a Know Your Rights card that is available on the internet, and we also have copies of that available in our emergency department too, so that when these issues come up or someone describes a lot of fear about deportation, at least you have some information to give them in the moment.
One last thing is, you'd be surprised if you actually reach out, like if you call your local legal services organization as a provider and make a connection, they're often ecstatic that someone in the medical community is actually reaching out to them. You can get an email address, and often what I do is I just I get the patient's permission, I get a name, an email address if they have one, or their phone number, which is generally the way, and just send a 2-liner by email at 3 a.m. saying, hey, this guy's here. They look like they might be eligible for a U visa. Can you follow up with them? And they are more than happy to follow up, because having a medical provider involved, you can actually make a pretty big difference later down the line when they're actually going through these legal proceedings.
Any other questions, comments?
Do you find it a barrier to get patient buy-in, especially considering you guys mentioned this population is often living in the shadows, seeking care when it's urgent, and you're asking them for their personal information, and you're just meeting them for the first time?
Yeah, I think it's an important question in terms of how do you actually identify this, and I think part of it is it's a subtle thing. I think we're experts in the field in emergency medicine, in that we deal with delicate situations all the time, like discerning whether or not there's child abuse going on, or there's domestic violence, or sometimes you have to read between the lines to get there, and the person has to be forthcoming. I think a lot of things, like Todd mentioned, you can kind of identify there might be proxies within the health system where you work locally, which might help you narrow down the population that you're looking for. And the other thing to think about is all the other things we mentioned, is trying to make it an inviting space as much as possible to make sure people feel comfortable coming forth and disclosing that very sensitive information to healthcare providers. Because you can imagine if everywhere there's a sense of persecution and criminalization, it's going to be very hard to come forward with that information.
Yeah, I think that safe spaces point is key, and I think when I present this to patients, I often say we have people who are free. They won't, they're not associated with law enforcement. They're not associated with ICE. They're here to help. And I think usually hearing that from a healthcare provider in a trusted space, they're often much more receptive than if they were approached on the street or in another setting.
Yeah, I think that's key, is the amount of trust you receive as a healthcare provider, and being able to leverage that to equip this person with some legal help is, because almost everybody I talk to has tried at some point to get some sort of legal help. Usually it's failed, or somebody's taken advantage of them, which is awful, and be able to plug them into something. And that's why I think it's just really important to have some sort of relationship with your local folks. And there are these attorneys all over the place. I've been amazed working in the Central Valley and stuff like that. There are these attorneys that are out there and want to connect with providers, because you do, you know, create this community around supporting the population, as well as, like Dennis alluded to, things like medical affidavits and medical resources for them, for their clients down the road. Huge. Any other questions?
All right. So, thank you for coming.
Yeah, early.
Yeah, bright and early.